असतौ योनिव्यापत्प्रतिषेधं व्याख्यास्यामः यथोवाच भगवान् धन्वन्तरिः. The Yonivyapad is a group of disorders where it contains many of the various abnormalities like either menstrual abnormalities, abnormal uterine bleeding set of conditions, sexual preferences, then structural abnormalities of the genital organs. Sushruta has described many of those conditions in the Nidana Sthana earlier, along with that the Garbhini Paricharya, but some of them are added in the Uttara Tantra. Again, the logic of adding these in the Balaroga chapter is again something which is unusual, which is not explainable easily. Anyway, the etiology of the Yonivyapati according to Sushruta is प्रवृद्धलिंगम पुरुषम यो अत्यर्थम उपसेवते वृक्ष दुर्बल बालाय तस्या वायु प्रकृति सदुष्टो योनिमासाद्य योनिरोगाय कल्पते. According to Sushruta, a relatively younger girl having sexual activity with a older person results in abnormalities of the total sexual organs of the body and reproductive system of the body that produces the Yoniroga. Whereas in Charaka Samhita, the Yonivyapata are described with as Nishvimshati Vyapado Yono Nirdistaha Roga Sangrahe Mithyacharanayah Taha Strinam Pradushtena Artavenacha Jayante Bijadoshacha Daivacha Snutaha Pradaka. Now, according to Charaka, the Yonivyapata are produced due to the abnormal behaviors or Dushta Artava, that's abnormalities related to the menstrual cycles, then Bijadoshacha, congenital or genetic pathologies, or Daivacha, the something which is extraneous. Now, so there is a bit of difference in the perception of the Yoni dosha in Charaka and in Sushruta. Now, according to Sushruta, the etiology or the pathogenesis of the Yoniroga are त्रयाणामपि दोषाणां यथास्वं लक्षणेन तु विंशतिव्यापदौ योनिः निर्दिष्टाः रोगसङ्ग्रहे मिथ्याचारेण या स्त्रीणां प्रदुष्टेन आर्तवेन च जायन्ते बीजदोषाच्च दैवाच्च श्नुताः पृथक्. Now Sushruta also repeats the same sentence mentioned by Charaka as mithyacarena, pradushtena artava, etc. But in the initial stages, initial sloka, he says that it is due to the sexual activity which is not within the normal pattern. Now उदावर्ता तथा वंध्या विप्लुता च परिप्लुता वातला चेति वातोत्थाः पित्तोत्थाः रुधिरक्षरा वामिनी स्रंसिनी चापि पुत्रघ्नि पित्तला च या अत्यानन्दा च या योनिः कर्णिनी चरणद्वयं श्लेष्मला च कफाज्ञेया षण्डाख्या फलिनी तथा महती सूचिवक्त्रा च सर्वजेति त्रिदोषजा. The 20 varieties of the Yoniroga, among them udavarta, vandhya, vipluta and paripluta are vatala are the vataja. Then Pittaja are Rudirakshara, Vamini, Sramsini, Putragni and Pittala. Then Atyananda, Karnini, these are Kafaja. And Shandakya, Shanda and Falini, Mahati, Suchivaktra, these are the Tidosha. Safedila Mudavarta, Rajakritsenam Jati, Udavarta Yoni Vyapad. In that condition, the menstrual blood flow would be having a foamy consistency. And that foamy consistency is usually seen when there is a massive bleeding. Quantity of the blood loss is more, then you may see the foamy consistency. Then Vandhyam Nastartavam Vidyata. Now, Vandhya is a Nastartava, where the total quantity of the menstrual blood flow is reduced or absent, that is amenorrhea. And Viplutam Nityavedaram. Vipluta is when there is a constant pain in that area. Pariplutayam bhavati gramya dharmya rujabhasham. In the Paripluta Yoniroga, a patient would have pain during the sexual activity, sparunia. Vatala karkasha strabdha shula nistoda pedita. In Vatala Yonivyapata, the surface of the genital organ, vagina, would be dry and less sensitive. You will not have the same sensation, as well as there could be pain. Chatasrushapi Chardyasu Bhavanti Anila Vedana. Along with this, there will be many of the Vata Lakshanas could be seen in these four conditions. Then Sadaham Praksharati Asram Yasyam Sa Lohitakshara. In the Lohitakshara, the patient would have painful and burning sensation during the menstruation, the blood will flow with the burning sensation. Then Savatam Uggiret Bijam Vamini Rajasayutam. Vamini would be expelling out the semen which is secreted into the vagina after the sexual copulation would be rejected. So there will be some even we have that kind of sort of situation where immunological reactions would occur and the spermatozoa would be destroyed. That kind of the condition is a Vamini. So it's a sort of a cause of infertility, a pathology which is not related to only the menstrual flow as such. Prasramsini Syandajetu Kshobhitadu Prasramsini would be having a sort of vibrations or abnormal movements of the uterine tract or spasmodic conditions, and as a result of the spasmodic conditions, the delivery, pregnancy and delivery would be difficult in such conditions. Stridam Hantigarbham Putragni Rakta Samsavata. Putragni would have a repeated abortion, even after the conception there will be repeated abortion along with the massive blood flow. Atyartham Pittala Yoni Lahapaka Juranita. Pittala Yoni patient would have burning sensation and fever, so on, signs of inflammation would occur. Chatusthapicadeshu Pittalingochayo Bhaveta. In all these conditions, all the Pitta Lakshanas also could be seen. Atyananda Nasantosham Grami Darbhena Gachati. Atyananda Yoniyapata would not have the pleasure, the usual feeling of orgasm or pleasure during the sexual activity. Karninyam Karnika Yono Sleshma Asrubyam Prajayate. Karnini conditions, there would be multiple polyps in the yoni, in the vaginal. So vaginal polyp are the Karnini Yoni Vyapaka. And it's due to Kapha and Raktaja Vyadi. Maichne Acharana Purum Purushad Adirichade. Acharana would be having a precocious orgasm. Orgasm even before there is a sexual activity. So our premature orgasm would occur in such conditions. So these are all the abnormalities of the sexual activities. Bhushascha Aticharanat Anya Bijam na Bindati. Then Aticharana Yonivyapata would be infertile. There would be no ovulation. The Bijam na Bindati, Bija would not occur. Anovulatory pathology. Shleshmala Pichila Yonihi Kandu Yukta Atishitala. In the Shleshmala Yonivyapata, there would be more slimy secretions in the vagina and itching as such. It again is a sign of usual local inflammatory conditions. Chatasrusa Pichadya, so Shleshmalingot Sati Bhaveta. Other kapha lakshanas also would occur in such conditions. Anartavastana Shanthi Karasparsha Maitune Atikaya Grihitaya Tarunya Palini Bhaveta. A Palini would have all absence of the sexual characters. So it's a primary amenorrhea with the absence of the sexual characters, and she would not also have a discomfort during the sexual activity, and tends to be obese. That's a typical feature of endocrine-induced primary infertility. Vivrta Ati Mahayonihi Suchi Vaktra Ati Samrta. Mahayoni and Suchi Vaktra, Suchi Yoni are where there is a abnormality of the size of the vaginal opening. Vivrta is where the vaginal opening is quite wider, and Suchi Vaktra is where the vaginal opening is narrower. Sarvalinga Samutthana Sarvadosha Prakojaha Chatusarvyadyashu Sarvalingochati Bhaveta. In all these conditions, Tridosha Lakshanas would be occurring, will be seen, and they are Asadhyaha, Pancha Asadhyaha Bhavanti Maha Yone Sarvadoshayaha. These are Asadhya conditions. Pratidosham to Sadhyasu Snehadikrameshate, Dadyad Uttarvastim Shabisheshena Yathoditana. In all the conditions, the Snehadikrama, as mentioned in the Chikitsa, so specific Doshagna procedures have to be followed, and Uttarabhastri is the more specific form of the treatment. Karkasham, Shitalam, Stabdham, Alpaspurshant Maitune, Kumbhi Swelei Upacharek, Sanu Poldaka Sanyudehi, Madhura Oshaka Sanyuktan, Veshavaram Stevanishu, Nikshipeta, Dare Chapi Pitailam Matandita, Dhavanani Chapatyani, Kurvita Apurananicha. In Karkashayoni and Shitalayoni and those who do not have the proper sensation during the sexual activity, Kumbhi Sweda is suggested. Kumbhi Sweda is a Svedana done by keeping a hot substance in a pot, and then the steam is directly exposed to the area where the Svedana has to be done, and the Kumbhi Sweda has to be done with the Anupa and Audaka Mamsa. Then Madhuroshada or Veshavara, these are to be added for the Svedana Dravya. Or there could be Pichu, Taila prepared with the different drugs could be kept as a Pichu, a wick has to be kept there. Or wash the genital organ with the different Tailas as Kashayas, or Apurana, the douche has to be given. Voshachosha Anvita Suktam Kuryat Shitam Vidhim Vishaka. In inflammatory conditions, Shita Vidhi has to be followed. Durgandam Pitiram Chapi Churnehi Panchakashayaihi Purayed Rajarukshadi Kashayascha Dhavanam. In those who have a foul smelling and slimy discharge from the vagina, Panchavalkala Kashaya has to be used, or Rajarukshadi Kashaya has to be used for cleaning. Yonyam Puyasravinyam Shodhana Dravya Samritihi Sagomutrihi Saravanehi Shodhanam Hitamishate. In those conditions where there is a persistent pus discharge, purulent discharge from the vagina, the Shodhana Dravya with the Gomutra and Lavana has to be used for the Shodhana. Brihati Parakalkasya Dviharidra Yutasya Kandu Matim Alpasprasham Purayed Dhupayet Tada Vartim Pradajyat Karninyam Shodhana Dravya Sambratam Prasranthini Gradabhyaktam Kshirasvinam Praveshet Pidhaya Veshavarena Tato Bandham Samachareta Pratidosham Vidadhyatya Surarishta Asavan Bishaka Prata Nisheveta Rasonat Udhrutam Rasam Kshira Mamsarasa Prayam Aharam Vidhajitaja. In Kandumatin, those who have itching over the area or those who have abnormal sensation, Brihati Falakalka with the Haridra, Daru Haridra and Haridra together can be used for Dhupana. Our Varti is suggested, Shodhana Dravya prepared Varti is suggested in Karnini, that's polyps, the vaginal polyps. Shodhana Dravya prepared Varti is suggested. In Prasramsini, where there is a ejection or rejection of the semen, Grita and Kshira has to be mixed together and it has to be introduced into the vagina, and it has to be covered with a fleshy substance. Veshavara is a fleshy preparation and a bandage has to be placed. So a sort of vaginal filling is done, which is generally not practiced now. Then in all the other conditions, according to the doshas, Sura, Arishta, Asava have to be given in early morning. And one of the general regimen which is suggested in all the Yoni doshas is a Rasona Rasa. Rasona Swarasa has to be taken, and Kshira Mamsarasa Prayam Aharam, the food has to be given mainly containing Kshira Mamsarasa, etc. Shukrartavadayo doshaha stanarogashcha kirtitaha klaibyasthanani mudasya garbhasya vidirevaja garbhini pratirogeshu chikitsa chapi udaharta sarvatatam prayungita yoni vyapatsu buddhimana apaprajata rogamsha chikitse uttarabhishaka. In other regimes which are mentioned in the Shukra dosha, Artava dosha, or Stana roga, or Klaibya chikitsa, Mudhagarbha chikitsa, and Garbhini chikitsa have to be applied in the management of the Yoniroga according to the conditions. Or Uttara Basti is one of the suggested treatment in all the conditions. Now from the current point of view, as I said, the Yoni Vyapati is a very diverse group of conditions. To limit them to one set of the diseases is not possible. But from the clinical point of view, the most common type of the diseases which we come across would be abnormal uterine bleeding. So abnormal uterine bleeding is one of the major issues which we come across in the clinical practice. Of course, other aspects also are important. I am not saying that they are not important, but because of the very high frequency of the diseases, we would be referring to this abnormal uterine bleeding as a major issue related to the Yoni Vyapat. The other factors like the sexual preferences and the issues related to the polyps and structural pathologies of the vagina, they are something which is related to the other branches, like say now in these days majority of the these sexual preference conditions, they are under the psychiatry group, and the surgical conditions like polyps, they are up to the surgical conditions, of course. So those are the very well defined conditions otherwise, so we will not go into that detail. But majority of the conditions which we deal with in the clinical practice and which can produce a sort of confusion would be abnormal uterine bleeding, and hence I will be just discussing that abnormal uterine bleeding to a certain extent, somewhat more detail. Now, abnormal uterine bleeding is now defined, the correct definition is as a change in volume, regularity or timing that has been present for 6 months or longer. A abnormality having for one cycle or 2 cycles is not considered as a abnormal uterine bleeding. It could be due to certain temporary issues. So when the condition is persisting, where there is a abnormality in the volume or regularity or the timing of these menstrual cycles for consistently for 6 months, then it is categorized as abnormal uterine bleeding. And they could be, abnormal uterine bleeding could be either absence of the bleeding, like something like Vandya, or irregular bleeding, or abnormal heavy bleeding, or bleeding in between periods. These are the 4 categories of the abnormal uterine bleeding conditions which we see. Now, from the current practice, now as far as the current gynecological practice, the abnormality is defined as per the Federation of Gynecology and Obstetrics, FIGO criteria 2018 system. The standard protocol of recording these is one of the universally followed method, where the frequency is mentioned. Frequency, the normal is in between 24 to 30 days. Then either it could be infrequent or absent, no bleeding at all, or more frequent where it is less than 24 days. Then duration normally is for 3 days. If the bleeding is prolonged beyond 4 days, that is considered as abnormal. Then regularity, the normal or regular is the shortest or longest cycle variation in between 7 to 9 days. Then irregular is the shortest or the longest cycle variation is 8 to 10 days. Then the flow volume, normal again in the FIGO, this quantitative measurement is not mentioned, but universally accepted is less than 80 ml per day. If it is more than 80 ml per day, then it is considered as abnormal. Then light and heavy is the other issue. Now, intermenstrual bleeding, normally none, there will be no issues. Then the presentation could be either random or there could be cyclical, predictable, where either early cycle, mid cycle or late cycle bleedings, and the causes would be different. Now, when it comes to the question of differential diagnosis, that would be presented. Then unscheduled bleeding on progesterone or regesterone gonadal steroids. When there is no patient who are not given any medications, that's not applicable. Then even after medication, if there is no bleeding, then that's an abnormal, which is suggestive of a primary pathology. If it is present, if after stimulation with the progesterone estrogen combination, then that means the sexual organs are present, but there is something like abnormality present there. So that's the general protocol of recording the conditions. Now, the quantitative as the frequency which is mentioned, or which is again followed by the other way, by Fraser criteria. Now, FIGO criteria is established in 2018. The other criteria, there is another standard protocol, that's the Fraser criteria, where the frequency is again almost same, but there the only one issue is about the quantity. Volume is heavy is more than 80 ml, normal is 5 to 8 ml, and light is less than 5 ml, which is mentioned specifically. Rest of the things are almost the same as such, and the duration of flow also is considered as 8 days, and 4 to 8 days is considered as normal, less than 4 days is shortened, and more than 8 days is considered as abnormal. This is more practicable from the current point of view. When we see the patients in India, majority of the patients we can consider this as the normal range as such. Now, as far as the causes of abnormal uterine bleeding, again, the standard differential diagnosis is also called as a Palm-Cohen formula. Palm-Cohen formula is a P suggests about polyp, A suggests about adenomyosis, L suggests about leiomyoma, and M suggests about malignancy and hyperplasia. C represents coagulopathy, systemic disorders of the bleeding. O suggests about ovulatory disorders. E suggests about endometrial pathology. I suggests about iatrogenic and not otherwise classified when you do not have the other reasons. No. So whenever a patient comes with an abnormal uterine bleeding, the causes could be any one of these. So you have to go for the clinical history taking as well as investigations related to the issues based upon the clinical presentation as such. So diagnosis of the conditions would be based upon these presentations. And the protocol as such, investigational protocol would be USG for polyps or hysteroscopy also to see the polyp, MRI for adenomyosis, and or USG for adenomyosis. The specimen hysterectomy specimen are containing fibroids or hysterectomy specimen containing endometrial cancers. Histology, these for carcinomas. Even pap smear consider is under the same. Then polycystic ovary is one of the most common condition which is seen, and USG is the investigations. Then others like Dopplers they may not be very common issues. Now again, patients presenting with amenorrhea, so that's how the abnormal uterine bleeding is assessed. From the clinical point of view, one group of the conditions are primary amenorrhea, which are quite common. The primary amenorrhea conditions could be again categorized into hypogonadotropic hypogonadism, eugonadotropic eugonadism, and hypergonadotropic hypogonadism are the major issues. And that means the patients who have a reduced development of the gonadal organ as well as the gonadal hormones are lesser. And the usual clinical presentation would be, there would be, if you study for the hormonal assessment, either there will be a gonadotropic hormone deficiency or prolactin level may be higher, or there could be a pituitary abnormality. So assessment of the hormonal system would be necessary in such conditions, and often the patients also would have the other accompanying symptoms like anorexia, stress and exercise induced conditions. Then eugonadotropic eugonadism is where sexual organs otherwise seem to be normal, but there is no bleeding at all. In such conditions, either of course pregnancy is one of the common conditions which has to be ruled out. If the patient presents with amenorrhea, the first thing which you have to rule out is a pregnancy. Then mechanical conditions like imperforate hymen, Mullerian agenesis, where there is a structural pathology, Asherman syndromes, where there is again abnormality of the secretions of the hormones, hormonal cycles in the body, or PCOS, the polycystic conditions. From the current clinical point of view, PCOS is the most common condition, so I will just deal with somewhat greater detail about that. Hypergonadotropic conditions are where the abnormality, the sexual organs are hypertrophied, but the secretions are lesser, which is seen in ovarian dysgenesis or androgen insensitivity syndromes, congenital pathologies, which are relatively rare. Another way of identifying or assessing a patient of primary amenorrhea patients where there is no ovulation at all, another way of assessing this would be by looking at the physical features. If the breasts and the uterus is present, then the patient may be either there could be abnormality of the thalamic or pituitary lesion, PCOS, or ovarian insufficiency. If the breasts are present but uterus is absent, that's usually the congenital pathology like Mullerian agenesis and or androgen sensitivity. And if the breasts are absent but uterus is present, which is usually due to hypogonadotropic hypogonadism, or there is a agenesis. So breast and as well as uterine is absent, then it could be due to enzyme deficiency or agonadism, genetic pathology. So when a patient presents with the primary amenorrhea, you have to look at the secondary sexual characters as well as the primary sexual organs condition, If the primary organ conditions are normal, secondary sexual characters are not present, that suggests about a hypogonadism condition. If the secondary sexual characters are present but the uterine organs are not present, not normal, it could be due to the congenital pathology of agonadism. If both are normal, visibly normal, but the patient has amenorrhea, it could be due to the conditions like polycystic ovarian disease or ovarian insufficiency. As far as the clinical conditions are concerned, majority of the patients come under this category where both the primary organ as well as the secondary sexual characters are present, but the patient may have amenorrhea. Then the polycystic ovarian syndrome or ovulatory dysfunctions, patients who have abnormality of the ovulatory dysfunctions, the most common condition is PCOS. And all the other conditions, hyperandrogenism, now it's a increased androgen secretion, which could be due to occupational, which could be due to the food as such. Then oligomenorrhea or amenorrhea, we could be the other presentation, and polycystic ovaries on pelvic ultrasonography. Now the causes for the polycystic ovarian syndrome as per their physiological changes are either there could be a typical features of the androgen excess like hirsutism, hairs grown over the area, and the maybe the physical characters also, the muscles they become bit higher, there will be obesity and so on. The other conditions will be there could be either amenorrhea or oligomenorrhea. Then a confirmation of the polycystic condition would be the ESD where the abnormality could be seen. So as per, and one of the most important causes for the PCOS now is the dietary factors, and incidence also is very high. Almost every third young active, sexually active age group of the girls would have a polycystic ovarian syndrome now, and that rapid increase is related to the dietary habits and the obesity which is accumulating over that, and it's a preventable condition. So in general, a heavy menstrual bleeding, another sort of the abnormal uterine bleeding, heavy menstrual bleeding, which is earlier was referred as menorrhagia, now categorized as HMB or heavy menstrual bleeding, is defined as blood loss exceeding 8 ml or bleeding that lasts longer than 7 days in each menstrual cycle. Now heavy menstrual bleeding, to confirm, there are many standard methods of assessing. One of the methods of assessing is pictorial blood assessment. Pictorial blood assessment, by looking at the color of the pad used, you may make out when there is a bright red color, that's usually suggests of a heavy bleeding. A dark or brown color would suggest about a store or a blood which was accumulated there for a longer duration. Pale red colors suggest about anemia or the serous pathologies, endometrial pathology. Orange is considered as the normal. Now, to confirm about this, there are standard pictograms to confirm whether there is an increased bleeding or not. Different sort of the pictorial diagrams are used. The most useful and practically, in suppose those who are writing thesis on the menstrual abnormalities, they need to have a pictorial diagram to record this increased bleeding, where the towel or that tampon which is used for the blocking is tested every day, examined every day, and the color and the size, that quantity is mentioned in the form of a table, and the day wise, that's how it has to be mentioned. This is a standard protocol of mentioning this, and the most common use is PBSC hymen, which is the most common pictogram which could be used. Latest is VAT menstrual pictogram, which was presented in 2000, and then of course 2014 there is another of the pictogram which is suggested, which could be used in your case sheets. So particularly to have an objective assessment of the menstrual flow, these pictograms are used for heavy menstrual bleeding conditions. Then intermenstrual bleeding is defined as bleeding between the periods. Causes could be pregnancy, sexual transmitted infections, iatrogenic, that's due to the medical interventions like contraceptive pills, steroids, etc., which also have to be considered as a possible conditions. Dysmenorrhea, the pain is often due to again another of the common clinical presentation, where there could be pain during the menses and accompanied by nausea, vomiting, and there again it could be presented as primary as well as the secondary dysmenorrhea. Primary dysmenorrhea occurs in the absence of no other organic pathology, and it's considered to be due to the prostaglandins during the menstrual cycle, which may be presented since menarche and continue till the late ages. Often primary dysmenorrhea gets cured after an episode of pregnancy. Once the patient conceives, the prostaglandin secretion may become normal. Then the other secondary amenorrhea are endometriosis. Mainly the most common are endometriosis or pelvic inflammatory disorders, which have to be ruled out and then they have to be treated as such. That's in brief about the menstrual abnormalities as we assess now. With this we conclude this chapter. इति सुश्रुतसंहितायाम् उत्तरतन्त्रात्मके कुमारतन्त्रे योनिव्यापत्तिनिषेधो नाम द्वादशोऽध्यायः अधीतः 38तमोऽध्यायः उत्तरतन्त्रे द्वितीयं कौमारतन्त्रं समाप्तं. That कौमारतन्त्र is over. So with this we conclude today. If there are any questions, try to answer. Then there are no questions, so we will wind up today.